Okay, so hello everyone. Thank you for coming. And today's session has been supported by Paladin, and I want to start with the land acknowledgement that the University of Alberta acknowledges that we are located on Treaty 6 territory and respects the histories, languages, and cultures of First Nation, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. And it's a pleasure for me to introduce our speaker from today. Our speaker is Dr. Gerold Thölking, and he's the director of the Department of Internal Medicine and Nephrology at the University Hospital of Münster, Median Hospital Steinfurt in Steinfurt, Germany. He was appointed Associate Professor of Internal Medicine at the UKM in Münster in 2017, and he did his nephrology training at the UKM and postdoctoral fellowship at the Institute of Physiology in Münster too, with a focus on renal tubular inflammation processes. And he has conducted several clinical studies in the field of immunosuppression after both kidney and liver transplantation. And his main topic of research, which is what he's going to present to us about today, is the influence of the pharmacokinetics of Tacrolimus and outcomes in patients both with liver transplant and kidney transplant. Thank you very much, and welcome to Alberta, Dr. Thölking.
Okay, then I'll start. Yeah, thank you very much for inviting me and give this talk to you. I'd like to talk about the CD ratio of Tacrolimus, and I hope it helps you a little bit in your clinical routine to individualize your Tacrolimus or your immunosuppressive regimen. This is a disclaimer. This is a conflict of interest. And during the next about 40 minutes, I'd like to talk about Tacrolimus. As most of you know, is established as the first-line therapy after renal and liver transplantation and other solid organ transplantations as well. We know from our daily doing that we've got difficulties with Tacrolimus achieving the right range of the target level, and we see adverse effects or events with Tacrolimus, and I'd like to show you something about that. I'd like to show you the different TAC formulations that are on the market, also in Europe and in Canada. Then I'd like to introduce you to the CD ratio that we established in a very easy version in 2014, and I'd like to show you some outcome data that we published during the last years, and other groups did as well, and I'd like to give you a little summary about that. After that, I show you two newer studies that we conducted about conversion from Prograf and Atrograf to Envasus. And at the end, I'd like to give you a little conclusion and a take-home message that you can use for your daily doing. So at first, I think I bring it to the hometown. The Elite Symphony studies that was Edmonton is very much involved in this study, and this is the study that showed that low dose tacrolimus regimens together combined with mycophenolate and prednisolone is the mainstay and the main immunosuppressive regimen used in renal transplantation, and it has superior things that are better for the renal transplantation patients compared to cyclosporin or everolimus or sirolimus. And the KDIGO guideline that we in Europe used usually it suggests that tacrolimus is the first line CNI that shall be used. And in liver transplantation, there is similar data. There's a meta-analysis that compared cyclosporin to tacrolimus, and this study clearly shows that tacrolimus is superior compared to cyclosporin, and many liver transplant guidelines therefore recommend that the CNI should be used as a cornerstone of the immunosuppressive regimen, and tacrolimus is superior or shall be preferred over cyclosporin A in liver transplantation. There's another Liver Transplant Society consensus statement that says the same, and tacrolimus should be preferred over cyclosporin. No, it's better in terms of preventing acute rejections in kidney and liver transplant patients, and many other outcomes are better with this substance than compared to cyclosporin A. So, as we know from our clinical routine, tacrolimus is not that easy to handle, and it has a very narrow therapeutic window. We see high intra and individual variances, and this is a study including 130 patients that took Prograf twice daily, and we see during the first 50 days after kidney transplantation that many patients do not achieve their target range here between 5 and 50. Although nowadays, this is a study from 2006, nowadays we use immense lower TAC ranges, and it's still the truth that we do not meet the target range every day. And so when we're above the range, we have problems with CNI nephrotoxicity. We see that the creatinine rises and that the eGFR gets lower. We have neurological disorders like tremor. And when we're below the achieved range, we have problems with acute rejections, chronic rejections, and this is not good for our transplant patients as well. So let me introduce you to the three tacrolimus formulations on the market. At first, there was immediate release TAC, or called Prograf, on the market. It's combined with cross-carmelose, and therefore it has to be taken twice daily as a capsule. The next player on the market was the extended release TAC. In this formulation, the cross-carmelose was changed to ethyl cellulose. It's also given as a capsule, and it only has to be taken once daily, and with this substance we achieved a better adherence, and the renal function. Some single studies show that it's a little bit better, but maybe to the adherence. That's the main point, that the adherence is getting better with this substance. The newest player on the market is the LCP TAC, or in Canada called Envasus PA. In Europe, it's only Envasus, and it's maybe taken as a tablet, and this tablet has a special new technology that is used in making this tablet. It's called the melt dose technology, and this enables also a once daily intake. And the very special thing is that compared to the conventional drug, it's not so, the particles are not that big anymore, and it has a higher surface area, a greater surface area, and therefore it has a better solubility. When you look at the intake, it already has a dissolution or a melting in the stomach already a few minutes after the intake, and you still see the dissolution about 11 hours in the colon transversum, and about 23 hours after the intakes, you still see dissolution in the lower parts of the colon, in the descending colon. So this is exactly what happens, or what we see, what's different with this TAC formulation when we look at the pharmacokinetics. With Prograf and Atrograf, we see the peak TAC levels about 2 to 4 hours after the intake. This is the ASCOF trial that showed a very high peak for the for Prograf in green, and a very high peak level for Atrograf in yellow as well. And what we see when we look at recipients, we see immense lower peak, and it's later about 4 to 6 hours after the intake with Envasus or RCP-TAC. And this seems to be one of the main important characteristics that's different in this drug, and due to the better dissolution of the substance in the intestine. Similar data were shown by a Spanish group published last year, and they compared Prograf in blue to Envasus in green, and they also showed that the Cmax is absolutely lower with Envasus compared to Prograf, and it has also just one peak at all compared to Prograf in blue. And they also could show that the substance Envasus has lower fluctuations as well. So the most important thing, or the most interesting thing in this study, is that they could show in green the inhibition of calcineurin, and this is more constant when we look at Envasus. The Prograf inhibition of calcineurin has 2 peaks shown in blue, and Envasus shows a very constant calcineurin inhibition all over the day with a very, very constant inhibition. So what are the conversion factors when we look at the ASCOF trial that compared the 3 substances? When we switch Prograf to Atrograf, we have a plus of 8% in regards of the dose. When we change Prograf to Envasus PA, we reduce the dose by 30%. And when we change from Atrograf to Envasus PA, we reduce the dose by 36%. So let me introduce you to the Tacrolimus CD calculation, or the CD ratio. This is a very simple calculation that you can do when you're visiting your patients or look into the patient's file next to the computer when you look at the TAC trough level. The CD ratio is short for concentration to dose ratio. You calculate it by taking the blood TAC trough concentration, which you usually use in your daily routine, and the daily dose that goes with the TAC trough level in combination, and you divide it by the daily dose. Yeah. For example, you have a CD ratio below 1. This means the daily dose is higher than the trough concentration. we define this as being a fast metabolizer. And when we have a patient that has a CD ratio above 1, so this means the daily dose is below or lower than the trough concentration, we define these patients as slow metabolizers. So this is a very simple approach to bring it to the bedside and to have a nice and easy system or tool to calculate your patient to be at risk or not. So, for example, you've got a renal or liver transplant recipient and a trough level of 6.3, and the patient takes 4 milligram Prograf twice daily, so 8 milligram per day. You just divide the 6.3 by 8 milligram per day, and so you receive a CD ratio of 0.79. But to be honest, we can see it just by looking at the two numbers, and we see, okay, all right, the CD ratio is below 1, and this is a fast metabolizer. So what are the studies that are based on the CD ratio that we published during the last years? This is the first study that we published in 2014. We included about 250 patients, renal transplant patients that just took Prograf twice daily. And we saw that already 1 month after transplantation, that the fast metabolizers developed a reduced renal function compared to intermediate and slow metabolizers. And these two groups were combined to 1 in all following studies. At the beginning, we had 3, and all following studies had 2 groups, only fast and slow metabolizers with a cutoff with about 1, below 1 and above 1. To be scientific correct, we used a CD ratio cutoff of below 1.05 and above 1.05. So we already have the 5-year follow-up of these data, and we included about 400 patients, and was not only the fact that the EGFR was lower 1 month after transplantation, it was also after 1 year and still after 5 years. The fast metabolizers shown with the box plots in blue and the slow metabolizers in red, and all time points at all time points we found significant differences with a lower EGFR in fast metabolizers. So does this work in liver transplant patients as well? We did a study together with our liver transplant physicians, and we included 115 liver transplant patients. We choose only 2 groups, fast and slow metabolizers with a CD ratio below 1 and above 1. And we also found a significant reduced renal function in fast metabolizers, is shown in the dashed line, compared to the slow metabolizers. This was significant as well. And this was a 3-year follow-up. So what was the reason for the reduced renal function? And therefore, we looked into the histological samples together with our Institute of Pathology. And we looked in the histological samples and just included patients who were taking Prograf twice daily. And we included all patients that where CNI nephrotoxicity shown as vacuolizations in the tubular cells were reported in the reports of the pathologists. And we used 4 steps of grading. below 10%, 10 to 25%, 25 to 50%, and above 50% of these vacuolizations in the tubular cells. So how many tubular cells are involved with these vacuolizations. And we correlated these damages in the tubular cells to the CD ratio at the point when the kidney biopsy was done. And we saw a clearly negative correlation between the CD ratio and the degree of the CNI nephrotoxicity, which means the lower the CD ratio, the higher the degree of the CNI nephrotoxicity. And to check what's behind this in the blood, does this have to do something with the pharmacokinetics? We took blood from our patients before they took the medication. This is time 0, then 2 hours after and 4 hours after. And we saw no difference at baseline. So the trough levels are the same, but 2 hours after intake, fast Taq metabolizers showed a significant higher concentration in the blood compared to slow metabolizers. And at 4 hours after intake, the difference was not shown anymore. So we think this higher level, this higher 2 hour level or peak level is the main explanation for the finding that fast metabolizers have a lower eGFR after several time points after kidney transplantation. So this is not, or this is just one part of the story. What a Norwegian group showed first in 2017 was that fast metabolizers, or what they call it, high patients with a high Tacrolimus clearance, which might be a bit exacter in a scientific way. They showed that fast metabolizers or patients with a higher clearance show higher rates of acute rejections in kidney transplant patients. They had a cohort of more than 1,000 patients, and the higher the clearance rate, the higher is the rate of acute rejections in a 90-day follow-up after kidney transplantation. We ask ourselves, is this true for our cohort as well? And we looked into our 5-year follow-up data, and we found the same data in our cohort with fast metabolizers having a higher rate of acute rejections as well. So what's the reason for this finding? We do not know exactly. Maybe it has got to do something with different CYP3A levels in the patients, but we never checked this. We just want to concentrate on the CD ratio. We're not so deep in pharmacogenetics. There are many groups on the world that are a lot better with this, and we do not focus on this. Maybe there are also lower Taq levels in some patients that are included in these studies, and maybe there are higher Taq level variabilities that can explain this. A very nice explanation comes from the Netherlands. They recently wrote a review paper about CD ratio outcomes and CYP3A5 genotypes in kidney transplant recipients. And they hypothesize that non-adherence is the main reason for lower CD ratios, and this non-intake of tablets may physicians lead to believe that higher doses are taken. The patient takes a higher dose, but they don't take the dose, and so you get a lower TAC level measured, and this might be the explanation for higher rejection rates. So we do not know exactly, but this is a very nice hypothesis, and I think this might be right. So what else did we find in our 5-year cohort of renal transplant recipients? We also found a lower survival rate in our patient that had a fast TAC metabolism. This was also confirmed by a French cohort with more than 1,000 patients, and they showed that patients having a fast metabolism have a 8% higher mortality or a less survival compared to slow metabolizers in a 5-year follow-up after kidney transplantation. And what's the main reason for death in these cohorts? We looked at our patients in this study, and most of the patients in both groups had cardiovascular events followed by infections. And yeah, this is what we know from our daily practice. These are the main topics or the main reasons why our patients die previously or earlier than other patients or the normal cohorts. So what else do we know about CD ratio based studies with examining fast TAC metabolizers? In the liver transplant cohort, we found, or not we, but another group in another group of liver transplant patients from Badu et al. They published that patients having fast TAC metabolism show more cardiovascular events, more lymphomas, more diabetes, and more arterial hypertension. From another cohort, we could show that patients with a fast metabolism have more BKV nephropathy, and or they suffer from more BKV nephropathy and have a higher rate of BKV infections, which is a very important virus for kidney transplant physicians. It's not that common known in liver transplant or heart or lung transplantation. This is a virus which infects the kidney and destroys the kidney. It jumps from one tubular cell to the other and makes a nephropathy that can also lead to a complete organ failure. So this is very important for renal transplant physicians. So it's also the other way around. If you look at the patients who suffer from BKV infection, they also have a lower CD ratio. Not only the one way around, it's also the other way around if you look into the patients with these infections. So let me show you two studies that we conducted about conversion from conversion studies where we converted patients on Prograf and Atrograf to Envasos. And this is a study that we conducted together with our liver transplant physicians. And we used standard release Tacrolimus, Atrograf or Prograf in this cohort. And we looked at 121 liver transplant recipients that came into our outclinic office, and between 2017 and 18, they were either switched to Envasos. 60 patients were switched to Envasos, and the other 60 maintained on the standard release TAC, Atrograf or Prograf. And all patients had a follow-up period of 12 months. So what we found was that the CD ratio as a marker also of bioavailability showed an increase, a significant increase during the 12-month follow-up. In numbers, we can show you that the increase in the CD ratio was plus 50%. And when we look at the daily dose, we could show that already 3 months after the conversion, we had a reduction of 33% of the daily dose. So does this have a clinical impact as well, the dose reduction and maybe a lowering of the peaks? Yes, interestingly, we found in clinical impact, and we looked at the eGFR, the renal function. And let me explain the slide to you. In dark gray, you find the patients that were switched to envasos, and in yellow-brown, you find the patient that remained on Prograf or Advograf. And time point 0 is the day of conversion, and this is the delta eGFR from conversion. And what we saw was that patients on that were switched to envasos showed a significant increase in eGFR, and the difference between the two groups was already significant 3 months after conversion. And interestingly, we do not know exactly why, but the patient that remained on standard release TAC showed a decrease of the eGFR during the 12-month follow-up, maybe a bit more than we had expected, but interestingly, the significance level was already reached at 3 months after conversion. So this was quite interesting, and we wondered if this is true for patients suffering from diabetes or from arterial hypertension. And indeed, we found a recovery of renal function in patients suffering from diabetes during the 12-month follow-up. It was significant as well, and for patients suffering from arterial hypertension and that were switched to envasos, we could also show this interesting increase of the eGFR, of the renal function. So in a multivariate analysis, we wanted to point out what are the influential factors on the eGFR development after 12 months. And the only factor that was involved or that was influential for this development was being in the group either envasos or remaining on standard release TAC. So this was the only significant influential factor. So as a nephrologist, I wondered, is this true for our renal transplant patients as well? For about 6 or 7 years, we switched some patients at our transplant center in Münster to some patients we switched to envasos. And in this study, we included 80 renal transplant recipients that received Prograf twice daily for at least 1 month. We could calculate the CD ratio already 1 month after transplantation, and this CD ratio defined 58 fast metabolizers with a CD ratio below 1.05, which is scientifically correct as described in the previous studies. And we included 22 slow metabolizers with a CD ratio above 1 or 1.05. All patients were switched to envasos 1 month after renal transplantation or later. And after the switch, all patients had a follow-up of 3 years. So what can we see with the patients in the patient's characteristics? We found no significant differences at all, but the time from renal transplantation to the switch was significantly different. In the fast metabolizers, the patient was switched about 2 months after renal transplantation, and in the slow metabolizers, 13 months after transplantation. So with this in mind, we looked at the TAC dose. What happened to the dose? We had a significant reduction already 10 days after the conversion in the fast metabolizer group and about 50% in slow metabolizers. And the dose was reduced in fast metabolizers about 60% after 12 months. And sorry, I can't see that. It's 67% after 12 months in the slow metabolizers. So what happened to the bioavailability, the CD ratio in this cohort? And this was quite interesting. We found an increase of bioavailability of more than 60% in both groups after already 10 days after the conversion, and more than 160% increase in bioavailability after 12 months in fast metabolizers, and about 140% 12 months after conversion in slow metabolizers. So this is an immense increase of bioavailability. We do not need so much dose, but we, the substance has a better intake. Does this have an influence on the outcomes, on the renal function? And in the slow metabolizer group, the 22 patients showed no difference from conversion until, or at all time points after conversion until month 36, so three years. But interestingly, we found already 10 days after conversion of fast metabolizers, a significant increase in renal function at all time points in a 3-year follow-up in this group. So the patients increased already 10 days after conversion, and although we have a dropout of about 16 patients in this last year, it's still significant, and one of the main points that we could show in this study. The manuscript is still under review, and I hope it will be published soon. This is the main finding in this study. So in conclusion, I think we can say the TAC-CD ratio, at least for us, is an established tool for risk stratification after renal and liver transplant, after liver transplantation. I know there's some study from Munich that this works also in heart transplant recipients. We think that the main adverse effects are caused by high peak levels, especially in the fast metabolizer group. And anyway, we need further prospective data. We need randomized controlled trials. All the data that I showed to you were retrospective analysis, and we need controlled trials, including factors like the EGFR, like acute rejections, like infections, mortality, diabetes, and many, many more. I think up to now we can say there are definitely alternative therapies to IR-TAC and ER-TAC, Prograf and Advograf, that are now available and beneficial and surely safe as well. Yeah, thank you for listening, and I'm ready for questions.
Thank you very much for this presentation. And you know, you can put your questions in the chat, or you can just raise your hand and open your mic. So the first question is from Asha and Chaudhry. Any experience with oral TAC absorption in patients with subtotal colectomy, terminal ileum to sigmoid?
Pardon? It was something with changing with colectomy? Or?
Yes, if you have any experience in using either you know, standard release or invarsors in patients with subtotal colectomy.
Okay, to be honest, not that much. In Münster, we have had about 5 transplantations with the lower intestinum, but we do not have so much experience in this. And with whole colectomy, we do not, I do not know exactly, but I think there's no patient in this group included in these studies. Yeah, to be honest, not that much. With total colectomy, not that much, and not that I can say anything about the differences using one or the other formulation. Not
Okay.
really. No, sorry.
Thank you. So, Dr. Banji, do you have a microphone that you can ask your question that is very long? No. Okay. So I will ask Dr. Banji's question. Dr. Banji is one of our transplant hepatologists. Thank you for the fantastic talk. Is there a time point after which you see the least improvement in eGFR? For example, if you switch to invarsors after 2 to 3 years versus switching 1 month post-transplant. So timing of switching to invarsors.
Yeah, I think if you want to improve something for your patient, you should do the conversion early after transplantation. I think if you do it 2 or 3 years after transplantation, you will not receive better eGFR values, or I don't know if there will be an improvement in lowering acute rejection rates. This is what I cannot say exactly, but I think if you do it early, and we know we can calculate the CD ratio somehow about 1 or 3 months after transplantation, when the prednisolone dose is reduced to a minimum. In Germany or in Münster, we reduce the TAC dose in renal transplantations to 5 milligrams, and this is remained for yeah, all the time after. So we continue prednisolone in renal transplant recipients always, and yeah, therefore yeah, I think if you do the switch within the first year, you can see a profit, and maybe not after that.
Okay, thank you. So Murray Wilson, do you have a microphone, and can you ask your question?
Yes, I sure can. So I'm a non-medical expert, but I'm wondering how, as a patient in these areas, how would you encourage us to ask questions about this ratio from the transplantation team that we're working with? How do we sort of draw this to their attention and ask them to give us advice that we can understand and act upon? Thank you.
Yeah, thank you very much for this question. It's a very important one. I think when you're fine with your medication, when your renal values, your creatinine, your renal function, your EGFR is stable, and you feel well with your medication, and you have a good relationship with your doctor, and your doctor says everything is fine, you've got no problems with rejections, your renal function is stable, you've got no problems at all, no tremor, no shaking hands or something like that, I think everything is fine. But if you have a rising creatinine level or problems with several infections, you could ask your doctor if he could calculate this CD ratio, or you could look at your trough level and your daily dose. You can calculate this very early after transplantation by yourself, just by getting the values from your doctor. And maybe you can give this advice just to look at it. There is no controlled randomized trial that gives a clear recommendation on switching patients, or that renal function and fast metabolizer is definitely lower in renal transplant recipients. We do not have controlled randomized trials, so I cannot really recommend that like a guideline. But maybe we can have a look at this topic, and we can have a look on the CD ratio, and this might wake us up and can help the transplant physicians to look at these patients. Maybe we do a AUC, area under the curve determination or measurement. So this means you measure the Tacrolimus level at different time points on the day, at 2 and 5 and 6 hours, and you have a look if this Tacrolimus level shows a very high peak, and you have adverse effects of your somehow with infections or tremor. This could lead to the decision to make a switch, for example.
I appreciate the response. I hope that your research is widely distributed, and that people that are in control of our lives with regards to TAC administration understand the points. Thank you very much.
Yeah, you're welcome. I know that the CD ratio is already used in prospective trials now in Germany on liver transplant recipients. And this is the main outcome parameter in patients that are switched after liver transplantation from Prograft to envasus. And we're pretty sure that we see an increase of bioavailability and an increase in the CD ratio. And I'm really excited what will be the outcome. I know there are studies on the way that are prospective.
Good. I don't see any more questions, but I would like to ask you a question. So you present is slow metabolizers and fast metabolizers. So how, like if they were two completely different phenotypes, but I guess there is a continuum. And related to that, how stable is this phenotype? And for example, in liver transplantation, the C to dose ratio will depend highly on the degree of liver dysfunction, or how well, if you have a rejection, the TAC levels will go to the roof because of liver dysfunction and decreased metabolism. So how stable is this phenotype?
It pretty much depends on, in renal transplant as well as in liver transplant patients, on the prednisolone dose that is given. So something is a point of genetics, CYP3A phenotypes in the gut, in the liver, in maybe even in renal cells. And the main thing that we can influence is the prednisolone dose. So if we have a very high prednisolone dose given at the time of a rejection or very early after transplantation, we see a lower CD ratio. When you get to the point that you have a continuous prednisolone level that your patient is on, the CD ratio will be continuous as well. I know there are a few more factors like the albumin level, the hematocrit. I know the body weight and the fluid status may have an influence as well, but yeah, this is not the problem so much in renal transplantation, but I think in liver transplant patients, you will see these problems a lot more often.
Okay, we have another question. Do you have a microphone to ask your question? Do you want me to read it? Okay, I will read the question. So, in the observational studies that correlated concentration to dose ratio to either rejection or declining renal function, were all the baseline confounding factors considered or controlled for?
The baseline factors, were they all? What was that?
So I think the question is about were there any other confounding factors that could, other explaining factors that could confound the relation between CD ratio and the outcome?
I think the main thing was the prednisolone dose, which was the main confounder, but we saw no significant differences between the doses given to fast and slow metabolizers. Yeah, I think this is the main influence and the main confounder in these studies, and this was always a big part in the review processes of these to publish these data. Yeah.
Okay, I don't know if there are more questions. Okay, if there are no more questions, we are very grateful for you to be here that late time of the day. And I just want to announce the next week ATI seminar, and Dr. Ian Rogers will be presented development of an ex vivo whole organ perfusion system, mouse, porcine, human for donor organ studies and de novo organ production. So the link is here for registration, and I think that will be all for today. Thank you again for being here today with us.